In this video, we describe a low anterior axis for retroperitoneal single-port robotic pyeloplasty, performed at Beth Israel Deaconess Medical Center. Our patient is a 41-year-old male with a long-standing history of left UPJ obstruction, initially asymptomatic and managed conservatively. He was lost to follow-up and represented with increasing left lung pain, severe hypertension, and declining renal function. At the time of surgery, his left renal function was 42.3%, and left T1/2 on MAC3 LASIK renogram was greater than 111 minutes after LASIK administration. In his MRI, we can see severe left hydronephrosis and a left crossing inferior renal vein branch. In this case, we use a low anterior approach to access the retroperitoneal space. For the SV access port, a 3 cm incision was made, 1/3 of the way between the left ASIS and the umbilicus. This incision allows us to access the retroperitoneal space with minimal movements. After incising the external oblique and internal oblique fascia and splitting the muscle fibers, we split the transversus abdominis muscle and use finger dissection to sweep the peritoneum medially, accessing the retroperitoneal space. This is the initial view after docking of the SV robot into the retroperitoneal space. Our camera is on the bottom, allowing a 12 o'clock arm to give anterior retraction. We started by working along the psoas muscle to identify the ureter and trace it severely. As we continue to work our way up to the renal pelvis, we identify the crossing vessel obstructing the UPJ. We divided the ureter at the UPJ. And spatulated opposite its blood supply. Please note the direct, almost tunnel-like path between our initial axis and our target, the UPJ, with minimal extra dissection and mobilization and advantage of the single-port approach. We then transpose the ureter anterior to the crossing vessels and anastomose it with the renal pelvis. Halfway through the anastomosis, we place a 6 French stent. Period of time was 140 minutes with minimal blood loss, and the patient was discharged on the same day. On follow-up, the renal scan shows significant improvement of drainage and resolution of flank pain.